Today I'll teach you about the fungal infections affecting the oral cavity, of course, and it's not just the oral cavity it affects the rest of the body as well. All right, so mycosis or mycotic basically refers to the fungi. I think you know this from your basic sciences. I hope everyone is aware of that. So mycotic basically refers to any kind of fungi or fungi or whatever you call it as. So the learning objectives, you have to understand different types of fungal infections. Two fungal infections which I'm going to discuss, that is candidiasis and histoplasmosis. Okay, and there is a terminology called as opportunistic infection, which I want you all to know because it's important to us as dentists. And some synonyms which are used for these fungal diseases, we must be aware because they're frequently used alternatively. And so the terminologies, both the synonyms, or if there are more than two synonyms, you need to be aware. There is no two ways about it. But it'll be easier because it will all refer to some kind of either clinical manifestations or histopathology or something like that. So it will be easy for you to remember. And then towards the end, we'll discuss how to diagnose and treat any fungal infection. It applies to all fungal infections. So let's start by defining what is mycosis. So like I said, it is the infection which is caused by the fungus or the fungi. And humans have a very high level of immunity to fungi in general. So there are several reasons why we are resistant to any kind of fungal infection. The first reason is the fatty acid content which is present on the skin, the pH of the skin, as well as the mucosa, which applies to your oral mucosa, which is alkaline in nature. Epithelial turnover, you know that there is a constant turnover of the cells, meaning the cells are repeatedly proliferated from the basal layer to the superficial layer and then they're shed off. I hope you know this. Okay, it's about 21 days. Okay, that's like the average epithelial turnover rate. There are also areas which take just about 14 days. So based on different parts of the oral cavity, the turnover rate differs. The average is 21 days. So this is when the cells from the basal layers of the epithelium multiply and they mature and they're shed off when they reach the superficial area. Okay, so because of this constant turnover, you know how the snake sheds its skin, yeah? So that happens once in many years, but we humans are doing it quite often. So you can just imagine it like that. Okay, so because of this, the fungi doesn't stay. It doesn't have like where it can like stick and cause where it can stay for a long time, make it as its home. That doesn't happen. Normal flora which is present, you know that there are bacteria which is present in your oral cavity, in your gut. There are normal bacteria, I mean not normal bacteria, you can say bacteria which are normally present. They're called as normal bacterial flora. Okay, so this will prevent the growth of the fungi, which is so nice, which is beautiful, until and unless your body immunity goes down. And also it happens when you take like an extended period of antibiotics. That's another reason why antibiotics are not prescribed just like chocolates. You know, you just don't keep on popping antibiotics just because you have something, because it alters a lot of things inside your body. And one of the main things is the bacterial flora in the oral cavity and in your gastrointestinal tract. So these maintain the environment of that area. But whenever there is an imbalance, when those bacteria die, the bad bacteria and the fungi, these overgrow. Okay, so that is prevented basically by your normal flora. Cilia of the respiratory tract, it is common sense that it protects your respiratory tract from entry of any of the microbes, whether it's bacteria or virus or fungi. So it is helping you protect from that as well. Okay, so these are all the reasons why humans have a resistance to the fungi infection. So this is the classification. No need for you to know the classification. Just for reference sake, I've put it. Superficial, cutaneous, subcutaneous. So these are all based on the areas basically. Deep fungal infection, this is what we are going to study, one of them, that is the histoplasmosis. There is systemic fungal infection also, we're not going to study here, that you will study when you go to general medicine or surgery. And the other very important infection, and this word I want you to know, that is the opportunistic fungal infection or opportunistic mycosis, and the main organism responsible for that is candidiasis. So what is opportunistic infection? So I told you there are normal bacterial flora present in the oral cavity. Whenever the immunity goes, and these are the normal bacterial flora which protect us from the unwanted infections, especially the fungi infection. But whenever the immunity of the person goes down, it could be because of diabetes, you could be undergoing a lot of stress, you could be having exam stress, which is very important reason, by the way. A lot of people end up having candidiasis, aphthous ulcers, all these things during their exams because of the stress. So the stress brings down your immunity. And many things, HIV, that is like the far extreme of your immunity going down. So many things when the immunity goes down. So the candida, which is present in the oral cavity, but it is not causing any infection. But when the immunity goes down, it takes that opportunity and causes the infection. That's why it's called as opportunistic infection. Okay. Other name for candidiasis is also moniliasis. So several names for this: mycosis, moniliasis, candidiasis. So the oral candidiasis, like I said, is a relatively common opportunistic mycotic infection which is seen in man, and that's why we're going to discuss it in detail because not only is it associated with say, for example, extended periods of antibiotic intake or stress or simple things like that, but also it is associated with the disease of the deceased. It's called as, that's your AIDS or human immunodeficiency virus positive people, or acquired immunodeficiency syndrome. Okay, so it is the lesion strongly associated with AIDS. Okay. I think I'll be discussing it with the viral infection. HIV is one of the virus we'll be talking about. So you will see how AIDS has, there are I think about 5 or 6 pathologies which are strongly associated, and one of them is oral candidiasis, a type of oral candidiasis. I think it's the chronic hypoplastic type. So Candida is, that's the reason why we are studying it, okay? Because it's common and it is associated with the AIDS, and plenty oral manifestations in AIDS patients. Candida is also called as toga candida because this resembles the white robe which was worn by the candidates in the Roman Senate. That's the reason why it's called as toga candida. And the genus Candida has about 150 to 200 species. We don't have to know all of them. The important ones are Candida albicans, Candida tropicalis, Candida pseudotropicalis. If you know Candida albicans, I'm very happy. That's the one we're going to focus on, Candida albicans. Even Candida means white. Albicare also means white. Okay, so albicans, albicare, to whiten. So both the words mean white. Candida also means the white robe. Albicans also means to whiten. Okay, so this is the most important species of the genus Candida, which is important to us as dentists. So Candida carriage in the oral cavity, in case of neonates, it's about 45 to 65%. In healthy adults, it's 30 to 45%. People with dentures, you can see quite high, 50 to 65%. And HIV and other immunosuppressive disease, it is 90%. Why it is seen in neonates? Neonates and newborns. The immune system is still not very well developed. Okay, they're still very weak, the newborn. So it's quite easy for them to have more number of fungi compared to people who have a developed immune system. So let's look at the classification. Very, very important. It's easy also because it's broadly classified as acute and chronic. Okay. Please look at the table. It will be easy for you to understand. Acute and chronic. So under acute, there is pseudomembranous candidiasis and atrophic candidiasis. And under chronic, there is hyperplastic candidiasis and atrophic candidiasis. Okay, so it is chronic hyperplastic candidiasis, chronic atrophic candidiasis, acute pseudomembranous candidiasis, acute atrophic candidiasis. And the other type is the mucocutaneous, which we will discuss at the end, and just few things which you should know about the mucocutaneous. So the main are these two. So let's look at them one by one. So this is the acute pseudomembranous candidiasis. It is also called as thrush. It appears as of course a white lesion. There is mild burning sensation of the oral mucosa, and whenever the patient is having this lesion, he experiences an unpleasant taste. There could be blister formation as well, I think in chronic conditions, and I mean if it is present for a longer duration of time, there could be blisters. Palate and buccal mucosa, dorsum of the tongue are the areas which are affected. So how does it appear? Why is the name pseudomembranous given? So it appears as an adherent white plaque which resembles the cheese or the curdled milk, as you can see in this clinical image. The interesting part about it is that it can be easily wiped off. Okay, that's why it is called as pseudomembranous. Pseudo means false, a false membrane, because it can be easily removed if you just use a gauze or whatsoever and you just slide it, it just comes off like that. Okay, that's why it's called as pseudomembranous, and the appearance is similar to the cheese or curdled milk. And these white plaques, of course, are composed of hyphae. Yeast is nothing but your fungi, desquamated epithelial cells, and debris. Okay, hyphae is basically like your how the bacteria have spores. That's how they reproduce. So that's the structure of your fungi, hyphae. Okay. So this is a picture of your pseudomembranous candidiasis, which is affecting different parts of the oral cavity. Here you can see this man, it's on the lip as well as on the tongue. This lady essentially on the tongue, even buccal mucosa is affected, and palate, very common site of oral mucosa which is affected by this. The next type is the acute atrophic candidiasis. The name which I want you to remember as a synonym is the antibiotic sore mouth. That will help you understand why this lesion is caused, and also in the exam point of view it is important for you. Okay, so because this is associated with taking broad spectrum antibiotic, this is something you should know. Okay, so tetracycline is one of the broad spectrum antibiotic. Erythromycin. Okay, so these are two very commonly prescribed broad spectrum antibiotics, erythromycin and tetracycline, you must remember. So if you have prescribed the patient these two and the patient comes back with a candida, you will know that it's because of the antibiotic and you will not freak out. That's the reason you should know about it. Okay, so it's associated with taking the broad spectrum antibiotics. Whenever you take a broad spectrum, the name itself says it is going to kill a lot of bacteria within your oral cavity. It's like it is effective on a huge range of bacteria, gram-positive, gram-negative, anaerobic, aerobic. Okay, so that is the reason why there will be alteration in the normal microbial flora, and that's when your candida becomes opportunistic and it causes the infection. Okay, so it's associated with antibiotics, and that's why it's called as antibiotic sore mouth. So the symptoms, again, it's a similar symptom. The mouth, you will have a burning sensation whenever you're drinking something hot. And as though, when you drink something very, very hot, your mouth gets scaled, meaning you get that feeling when you drink maybe a hot cup of coffee or something, especially liquid. So that's the feeling which is there constant. The patient feels it constantly. And there is a bald appearance of the tongue. What are present on the surface of the tongue? What are the structures which are present on the dorsum of the tongue? So they're the papillae. Okay, there are a lot of fungiform papillae, filiform papillae, circumvallate. All these are present on the surface of the tongue. So they all become lost, and the tongue appears bald. So clinically, the clinical features will be the erythematous mucosa. Because of the bald appearance of the tongue, it appears reddish. It is affecting the junction of the soft and hard palate as well, and the angle of the mouth, that is the commissures, and numerous erosions. Erosion meaning something which is removed. Okay, so like I said, the papillae are lost, so there are areas of erosion on the tongue, and there is an intense inflammation. So this is how it looks. This is a localized area of erosion which you can see. Yeah, can you see here? So this is the reddish erosion which you can see. Even here it's a localized erosion, whereas here you can see the entire tongue is bald. The entire tongue is affected. Here again it's a localized area. So that was the antibiotic sore mouth. Okay, and whenever you give them B complex or something after your broad spectrum antibiotic, then the condition goes back to normal. Those were the two acute type of candidiasis, that is acute pseudomembranous, and the second one was antibiotic sore mouth, or the erythematous candidiasis. The second is the chronic type. Again, there are two different categories under it: hyperplastic candidiasis and chronic erythematous, or the atrophic candidiasis. So chronic hyperplastic candidiasis, the other name, very important, I want you to remember, is the Candida leukoplakia. This is the type which is associated with the AIDS, so it becomes very important. So clinically, it is seen usually above 50 years of age. Men are more commonly affected compared to the women. And the site which are affected in a decreasing order, commissures are nothing but the angle of the mouth. Okay, cheeks, palate, tongue, and the lips, and it could be either homogeneous or it could be speckled. The lesions cannot be wiped off, although clinically it could resemble your pseudomembranous candidiasis, but if you try to wipe it off, it is not going to be wiped off. And there are multiple irregular firm nodules which are seen on an erythematous velvety mucus background. Quite a description that is. So you can see here, so we are using a spatula to try to scrape it off, but it's not coming off like your pseudomembranous. Otherwise it usually comes off. Okay, so this is how it's going to look. That's why it's called as leukoplaking. So it's the exophytic whitish growth. The second type of the candidiasis is the chronic erythematous or atrophic candidiasis. The other name for it is denture stomatitis. Okay, so the denture sore mouth is the other name as well. So I want you to remember, chronic erythematous type is nothing but denture stomatitis. Denture sore mouth is the other name, so it's similar, so it's easy to remember. Okay, so as the name implies, it is associated with people who are wearing dentures. So erythematous areas, which is seen right underneath the area of the dentures which are worn by the patients. So why do you think it happens? Why there is a candida lesion underneath the denture area? Poor hygiene. Basically, the patients, you have to give them instructions when you give them a denture. You have to give them an instruction saying that you have to take it off in the night, clean it, and put it in a bowl of water, and then wear it in the morning. What these people do, these old people, first of all, they're very forgetful. They suffer from dementia. or just general aging issues. So they just wear it and they go to bed, and they're tired. When they're tired, they just don't want to go through that whole uh, process of doing all this. So they just go to bed wearing the dentures, and that's the main reason why there is candidal growth underneath it. This is a removable denture. This is a complete denture wearer. So even under the complete removable denture, it's the same scenario, same etiology which happens. So the patient is not removing the removable denture at all. He is wearing it 24/7. So that's the reason why you will see candida right underneath it. So there will be a clear demarcation between the affected mucosa and the normal mucosa. I don't know if you can appreciate. Here you can see very red mucosa, and right behind it where the denture flange ends, you will see pinkish normal coral pink color of the mucosa. Okay, so that's one of the telltale sign that it is a denture stomatitis or denture sore mouth. There will be pain and burning. This is associated with almost all the candidal infection. The other type of the chronic candidiasis is the chronic atrophic candidiasis. The other name for it is angular cheilitis because it is seen at the angle of the mouth. That's why. And pearlish, this is a very common name which is used as well. So like I said, there are no two ways about it. You just have to memorize all the synonyms. So for chronic atrophic candidiasis, it's angular cheilitis and pearlish. And the symptoms are a red fissured lesion, as you can see here. Okay, and it is constantly red because it is irritated and raw. This is the most commonly used area, right? You're constantly talking, you're eating, you're drinking. So your mouth is one of the most active areas of the body. So it is always irritated and raw because whenever you move, it doesn't have time to heal. Sometimes if the patient has lip biting habit, then it can be circummural, not just at the angle. It can be seen all around the mouth. If it is just lower lip biting, then they will be around the lower lip, but some will have, they keep doing both upper and lower. So they'll have circumoral, meaning all around your mouth. So there was one developmental disorder, what people thought called as median rhomboid glossitis, which is now considered as a chronic atrophic form of candidiasis. It is no more considered as a median rhomboid glossitis. Earlier, it was thought to develop because of the persistence of the tuberculum impar of the developing tongue, because it does not withdraw during the development of the tongue like it is supposed to be or like it is meant to happen. And that was the earlier concept, but now it is thought to be candidiasis. Okay, it is present anterior to the circumvallate papillae, and it is present as oval or a rhomboid area of white or red, based on whether there is erosion or there is just whitish growth. And this median rhomboid glossitis or candidiasis may cause the central portion of the dorsum of the tongue to lose the filiform papillae. So that's why I said that the term erosion is used for the loss of the filiform papillae. And because it is candidal infection, Candida is it spreads very fast, the fungal infection, from one area to another. And because the tongue is constantly touching your palate, so there is a lesion from the tongue which is transferred to the palate, the candidal infection. In fact, that's how they identified this as a fungal infection and not a developmental anomaly. So that's when it spreads to the palate. It's called as kissing lesion because it is happening because your tongue is constantly kissing the palate. The last type is the mucocutaneous type. There is a localized form which is resistant to the treatment, and it occurs in the first 2 decades of life. And the nails and the skin are involved in this type. The familial form is autosomal recessive. And the iron metabolism is affected, cell-mediated immunity is affected, and 50% of the cases is seen in association with the endocrinopathy. This is what I want you to remember when it comes to the mucocutaneous type. There is nail and cutaneous involvement, iron metabolism, and endocrinopathy. If you remember these things, that's enough. There are also other systemic conditions like hypoparathyroidism, Addison's disease, and diabetes mellitus as well are seen in association with the mucocutaneous type. So let's see how a diagnosis can be done. First of all, you have to take a detailed history of the patient, whether he's under stress, whether he's having diabetes, whether he's having, say, for example, AIDS or any immunocompromised condition. So all these are history which you need to take, and then of course you see the clinical picture which we discussed just now. And then the first step which you can do is the cytology. That is, you just take a swab of the area and then look under the microscope, stain it of course before that. And the second is you take a biopsy. That is, the tissue can be removed and can be further examined as well if you don't see much in the cytology. Or maybe for a confirmation, you always go to the histopathology. It is the gold standard of diagnosis. And if things are still not clear, then you can do culture. I think you know from microbiology, you must have studied about the culture. So you see which is the organism which is causing the lesion. So diagnosis, for if you're taking a biopsy, then the stains which are used are periodic acid gift stain, Gomori stain, methenamine silver stain, and even H&E stain. You can do gram stain because these organisms are grams positive. Cytology can be done using 20% potassium hydroxide. Culture, like I said, is the most accurate method for any infection, whether it's bacterial, viral, fungal. Culture is the most accurate method. That's why they say that these days especially they don't prescribe antibiotics unless they do a culture, and then only they give you the antibiotics. And of course it takes a longer duration. Earlier it used to take 3 to 4 weeks based on the organism. Actually, based upon the organism, the culture takes that many days, but within 2 to 3 days or a week can be considered as a standard. And Seborrhoeids agar is used to grow these organisms. It is the fungi. And DNA probe, which is a quite expensive method, of course, and not something which you should just ask the patient to do. This allows for immediate identification of mycelium phase of hyphae. Probably if you're doing research, if you have a grant, if you have the access to a lot of these techniques, then you can do that. So this is how it appears in the cytology. You can see a lot of exfoliated cells, oral mucosal cells, oral epithelial cells rather, and these are the hyphae. Okay, so these are the hyphae which are indicative of your fungal infection. So in a higher power micrograph, this is how it looks. It looks like a long thread-like, not thread-like, thread-like will be very thinner. This has a proper body, as you can see, and these are the eruptions. So these are the smaller hyphae which are coming out of the main hyphae. These are the exfoliated epithelial cells. This is a tissue biopsy. These two were cytology. This is a tissue biopsy. So you can see epithelium, connective tissue, and the superficial most area is completely invaded by the fungi. All these thread-like structures which you see, this is a scanner. So scanner view, you can see a lot of fungi which is present. So the treatment for this is generalized state improvement. You should try and improve the immunity of the patient. If the immunity is compromised, you can also give immune boosting drugs, antifungal drugs which are prescribed. Topical, if you're asking the patient to apply, it's nystatin, and systemic are ketoconazole and fluconazole. And for oral cavity, you also have like a mouthwash kind of but this can be swished inside the mouth for a minute and then swallowed. Okay, so even such kind of formulations are available. Okay, And the second fungal lesion is the histoplasmosis, because it causes deep fungal infection. So I just wanted to discuss it. It's very small information which I want you to know. So these are organisms which are seen within the histiocyte or the macrophage. As you know, they're a part of the immune system, right? So your histiocyte or the macrophage. That's why it's called as the histoplasmosis. You will see the fungi within the histiocyte. Okay, it's also called as Darling's disease. That's the other synonym. And the causative fungi, the full name of it is Histoplasmosis capsulatum. So like I said, this is the histoplasm, and you can see these round structures inside it, plenty of them. So this is the descriptive picture for you to understand. So that's the histoplasmosis. Okay, so this is a structure. So this is a higher power micrograph of the same. So you can see how your histiocytes are filled with the organism. So you can do the same things for the diagnosis, whatever we described: cytology, histopathology, culture, serology even, and your biopsy.